Next talk on SACS Beginner's Perspective by Dr. Aradhi V. Panikar, and she'll be talking. She's currently working as a consultant cataract surgeon at Precise Eye Hospital, Mavelikara. Over to you, Dr. Aradhi.
Thank you. Good afternoon. I would like to take you through SICS from a beginner's perspective. The anesthesia can be peribulbar, retrobulbar or subtenons, and the initial steps include preparation and draping, putting a bridal suture, doing a conjunctival peritomy, sclerocorneal tunnel, capsulotomy, hydro procedures, nucleus prolapse and delivery, and the final step is IOL insertion. We'll go through each step one by one. Preparation and draping. Betadine scrub should be started and then centrally and then move peripherally. Do not return back to the eye. The betadine is allowed to dry up for 2 minutes. Elevate the superior eyelid and place the drape directly over the eye. You should get all the eyelashes under the drape. The putting a bridal suture is one important step, and it is mainly done to maneuver the globe, and it also provides counter traction during nucleus delivery. It is done with a double angulated forceps and held with tip pointing face down towards conjunctiva, and superior rectus is fixed and held with the help of the toothed forceps. You should move the muscle from side to side because we have to test hold of the muscle and make sure that the globe moves accordingly. This is usually done with a 4-0 silk suture. The complications that can happen during bridal suture is globe perforation, bleeding, muscle injury which can be laceration or avulsion, and post-operative ptosis. Next is doing a conjunctival peritomy. This is opening of conjunctival flap. The forceps is held with a non-dominant hand and conjunctival scissors with the dominant hand. The flap is based towards the fornix. This should be initiated at 10 o'clock. And the ideal conjunctival peritomy exposes the blue limbal zone without any overhanging conjunctival epithelium. The peritomy should be approximately 8 mm in length and 4 mm in width. After a proper blunt dissection, there should be bare sclera at bed without any islets of tens. Next, we can do a cautery that is wet field bipolar cautery, which allows visualization of instrument during tunnel creation. This is mainly done to minimize the bleeding into the anterior chamber, both intra and post-operatively. The disadvantage of cautery includes scleral thinning and scleral necrosis, poor wound healing, etc. The ideal cautery should be a point cautery done to scleral bleeders only. The cautery of the limbal blue zone bleeders has to be avoided, and it should not be applied after scleral incision and tunneling. The paracentesis, that is side port, should be put 1 to 2 clock hours away from the internal corneal incision. It helps in AC depth maintenance, staining the anterior capsule and cortical cleanup. The staining the anterior capsule, initially the air is pushed into the anterior chamber. Trypan blue is used to stain the anterior capsule and then it is washed out. The anterior chamber is maintained with viscoelastics. Next is a main important step of SICS cataract surgery, that is self-sealing cataract incision. The external scleral incision is made with the help of a surgical knife or blade. The tunnel is made with a crescent knife and the internal incision with a keratome. The external incision should be 1 to 2 mm posterior to the limbus. This can be in various shapes like smile, straight, frown, chevron and inverted batwing incision. The incision depth should be at ideally half to 3/4 of the scleral thickness, and the sclerocorneal tunnel construction is done like sweep the incision with the tip of the crescent blade to make the incision smooth, non-ragged and of uniform depth. You have to judge the depth of the incision by looking at the blade transclerally. Now propagate with the swiveling action in both sides. The lateral swiping movement should be done so that the tilt of the blade is along and equal to the contour of the globe. If it is going too superficial, can go for a buttonholing, and if it goes too deep, you can get a premature entry. Now extend the tunnel up to 1.5 mm into clear cornea. Use a bevel down keratome and a dimple down technique to enter the anterior chamber and create a third plane for a valve defect. Once the anterior chamber is entered, keep the keratome parallel to the plane of iris and extend the tunnel with forward cutting movement. So this is the measurements of the external incision, ideally 6.5 mm in length, 1.5 mm from the limbus to the incision, and internally also 1.5 mm. The internal incision should be around 7.5 millimeter in length. The complication that can happen during tunnel is irregular incision, buttonhole, premature entry, and DMD. Next is a very important step, that is capsular opening. That is, opening the anterior capsule should be stable enough to prevent the anterior capsular tears from continuing to the posterior capsule. Should be of adequate size. Can be done as continuous curvilinear capsulorhexis, can opener technique, or envelope capsulotomy. Done with instruments Pierce Hoskin or Colibri forceps, bend cystotom needle, capsulorhexis forceps, the AC maintained with viscoelastic. CCC is the most commonly done procedure. Puncture is made in the central anterior capsule and it is directed peripherally, either in a clockwise or counterclockwise fashion. The tear is held in a circular fashion. The control is achieved by grasping 2 clock hours away from the free flap edge, closest to the leading fold of the capsule. The good thing about CCC is that it allows for an easier cortical cleanup, promotes stability and centration of the IOL, resists anterior capsular radial tears, safe hydrodissection, and in the back lens rotation. The bad thing is it needs more experience to master. Larger CC can promote IOL dislocation from the bag, and small CCC you'll have difficulty in prolapse of the lens into the anterior chamber, and it requires excellent visualization. The can opener technique is done. The good thing is that it is easier to learn. Learning curve is short. High number of tears shares forces, thus reducing the chances of radialization. But bad thing is that you will find difficulty during the cortical cleanup. That is, capsular tears tags will be difficult to differentiate from the cortex. Hydro procedures can be done as dissection and delineation. Dissection is conventional hydrodissection and the cortical cleaving. Conventional is separation of the superficial cortex from the epinucleus, and the cortical cleaning is separation of cortex from the capsule. After doing hydro, while doing hydro, you have to look for the advancement of the fluid. If there is anterior movement of the nucleus, stretching of the CC and deepening of the anterior chamber. The mistakes mainly done is you'll have difficulty in tracking the capsular margin, and if you inject hydro without seeing the margin, then doing a hydro through side port in a viscofilled eye, less fluid injection can result in an incomplete hydro, and more fluid injection can go for chances of PCR. The hydro delineation is separating the outer epinuclear shell from the endonucleus. This is done mainly in case of PPC. Nucleus management can be nucleus prolapse and nucleus delivery, and adequate capsulorhexis should be done after a proper hydro dissection. One pole of the nucleus tilts forward, then you can hydro or visco cannula is manured underneath the rhexis margin. Then the equatorial edge of the nucleus is dislodged out of the capsular bag. The whole nucleus is rotated into the anterior chamber. After that, very important step is cortex removal, which is done with a Simcoe cannula. And initially, you tackle the most accessible parts, such as the inferior and the nasal. After that, the cortical material floating into the anterior chamber is aspirated. Then the cannula is placed beneath the capsular margin. Cortex is engaged and it is brought to the center of the pupil. Then only aspirate. Don't aspirate it at the edge. When pulling the cortex from behind the iris, to and fro movement is done to loosen the cortex from capsule at the equator. Then the final step, the IOL insertion, fill the anterior chamber with visco, hold with McPherson near the upper dialing hole, and to introduce into the tunnel. After leading haptic enters the AC, you tilt forward and direct towards the 6 o'clock. Then keep pushing till the leading haptic is completely in the bag and the lower dialing hole at the pupillary border at the 6 o'clock. Now gently release and withdraw the forceps. Grasp the trailing haptic with McPherson forceps, rotate the lens, and then as you tuck the trailing haptic under the edge of the capsule. Now, to confirm whether it is really in bag or in sulcus, if it is really in bag, you can see the stretch lines in the center of the posterior capsule, and also visualize the shiny appearance of anterior capsular rim over the haptic. Wash the viscoelastic, check for the wound integrity, generally tap on the cornea or the limbus opposite to wound with hydrocannula, hydrate the side port. After that, you can inject the intracameral antibiotics. Check the wound again. The indications for suturing are a leaking tunnel, premature entry, pediatric patient, or posterior PCR with vitreous disturbance. Finally, you can give the subconjunctival injection, remove the speculum, recheck the eye, apply ointment, and keep an iPad and send the patient. Thank you.
Thank you, Dr. Arathi. Any questions?